So I would like to introduce Professor Carl Philpott.
Oh yeah, right. Hopefully you're seeing what I'm seeing.
Yes, yes.
So thank you for inviting me, and I was listening to Duncan, and so I know that Duncan's probably now the expert as much as the the patient representative, and so it's probably covered a lot of the salient points already. But nonetheless, I'll talk about the sort of the epidemiology of smell loss and some of the information around that. So let's see if these slides will go forward. Well, I'll start with an excerpt from the Man Who Took His Wife for a Hat by Oliver Sacks, as featured in the book Aroma. And he said, "When I lost my sense of smell, it was like being struck blind. Life lost a good deal of its savour. My whole world was radically poorer." And I think, what the work that Duncan and I do with Fifth Sense is really kind of, trying to bring that to the fore, and sort of this understanding that actually here's a common problem that most people just sort of really take for granted until actually it becomes a problem for individuals, and society is largely blind to the problem of smell loss. And the reality is that smell loss actually is very common. There are a number of studies been done over the years, and they vary in the way they've collected the data. We think that complete loss of smell, or I should say absence of smell, because that then takes into account people who are born without smell loss, affects at least 1% of the population, but we think it's probably around the 5% mark coming up to date. And obviously the coronavirus pandemic has, we think, added over 250,000 people to the smell loss equation in the last 12 months. So that's a considerable increase as a result of that. If you then consider the reduced sense of smell and smell distortions, then we think that the overall prevalence of olfactory disorders is probably over 20%. And that's particularly because over the age of 65, we see natural declines and we see associations with things like Alzheimer's disease. So yes, I mean, depending on the studies you look at, there is a sort of variation. Number of studies, sort of the way they've gone about this. So the National Geographic study looked at sending out sort of mini scratch and sniff kits to their readership. I think they sort of polled about 3 million people in the US back in 1986, and they found that 1.2% based on this small short smell test were rated as anosmic. The more recent sort of widespread study was the Spanish Olfacats study, and that was conducted in about 10,000 people and sort of around the Barcelona area. They found sort of lower rates of anosmia, but then much higher rates of hyposmia, so that's a reduced sense of smell. And they found that risk factors included male sex, low educational level, previous head injury, pregnancy, and age. The graphic on the right there shows an online international survey that was done in 2019, and you can see the various sort of causalities there and the sort of range according to the different studies that have been done of prevalence. But typically, as Duncan's already elucidated, the sinonasal disease, that's things like chronic sinusitis, tends to come in as a front runner with viral infections such as coronavirus coming in second. And then we've got the sort of idiopathic cases, which means that we don't find a particular cause for the smell loss. And then head injuries are solid fourth, with another list of other causes coming in sort of after that. So if we look at that in a UK context compared to other sensory losses, and you look at the data from the Royal National Institute for the Blind, then there are about 2 million people with sight loss in the UK and about 0.8 million with profound hearing loss. So if we say that 5% of people are anosmic, then actually smell loss is more common than blindness and profound hearing loss. So a lot of people are surprised about that statistic. This was a study done in ENT departments across the German-speaking nations of Germany, Austria, and Switzerland, published back in 2004, and they were just really looking at the sort of common practice of ENT and what smell and taste disorders came through the door. And for those who don't speak German, basically the large chunk on the pie on the right represents the sort of nose and sinus problems collectively with the respiratory bit. So those two biggest bits of the pie are the kind of the things in the nose that kind of potentially block airflow to the smell receptors. You can then see post-viral, that's the obvious one there. idiopathique is that group of the unknown. And then the next one is the head injury, the Schedel-Hirn trauma, which was sort of 5% of what people were seeing in clinics. So for me, running a specialist clinic, actually, head injury, which is the bar, the sort of third tallest bar here in the display, is a very common presentation and probably counts for about 20% of all the people that I see in the clinic. So, and this is just a recap because I think obviously Duncan went over this, but essentially we can break down smell loss into things that block the airflow into the nose, and then problems in the sort of nerve pathways from the smell receptors up to the areas of the brain where the signal is received. And as we'll discover a bit later on in the talk, head injury can obviously affect various parts of that second part of the pathway. And then there are another list of sort of small print causes which we can sometimes sort of elucidate as causes for smell loss. So just to mention a little bit about risk factors, as I've identified already, age is very much a sort of a known risk factor for decreased olfactory function, and we know that over the age of 65, part of the little structures inside the area called the olfactory bulb, which is like the relay station for the smell nerves as they go from the nose to the brain, those start to kind of disappear after the age of 65, and certainly by the age of 80, a lot of those have disappeared. So we know inherently that our sense of smell does decline with age, and so there's an inevitable sort of deterioration there as we get older. And so we see much higher rates, so at least 20% over the age of 65. This is the interesting bit around gender, because the evidence is that men are worse affected than women, in a nutshell. And some theories behind that are that hormonal differences, so the estrogens and progesterones, may have a protective effect against cognitive function and olfactory decline in women compared to men. But if you look at my clinic, there are twice as many women turning up as men. So women value their sense of smell more than men, even though men seem to be more affected by smell loss. And this is very much a sort of factor that we see coming out in a number of our studies that we've done through Fifth Sense, show this time and time again. 60% or more of the participants that can respond to our studies are female. What about race and ethnicity? There's actually sort of little evidence around this, but there is some evidence from some American studies that perhaps African Americans may have worse smell scores than their counterparts from other ethnicities. What about other factors? So there's some conflicting evidence here that perhaps higher socioeconomic status has associated with decreased olfactory income in one study, the Beaver Dam study, and then another sort of more recent study in the States and suggested the opposite, showing sort of sorry, it was the Kane study, which is from Korea, suggested lower income was an issue, but then the most recent American study suggested that actually there was no obvious sort of link there. So it's one of these that isn't very clear cut. But certainly the educational level did appear to have a sort of link both in the Korean study and the Olfacat Barcelona study. So there was a sort of match with educational level, so poor educational level and poor olfactory function. I think Duncan covered the terminology. Essentially, we can talk about quantitative smell loss, so anosmia. Sorry, actually, that parosmia should be down here under qualitative. Apologies for that. So it should be anosmia and hyposmia, and then qualitative things are parosmia and phantosmia, which are the distortions of smell and the sensation of smell without a stimulus. The smell distortions can have quite a significant impact upon patients' well-being, and there are a number of issues that we've explored through our previous studies through Fifth Sense, and certainly polling the membership has seen that depression and anxiety are very common amongst our members, with over a quarter receiving specific treatment and another quarter taking sort of self-help over-the-counter remedies. And the other key factor is that patients experience weight loss and weight gain in equal numbers. So people seem to go one of three ways. They either kind of manage to sort of steer a steady course, or they lose weight because they lose their appetite due to the lack of stimulation from smell, or they go the other way and they seek every bit of food possible to try and create some sort of stimulus for their appetite, and they gain weight. And we can see the sort of the various responses to the questions that we posed in this particular study, and you can see that food and drink and hazard warning were the sort of top hitters in terms of the things that people were most bothered about. And we can see under those that experience the parosmia and phantosmia that again, weight loss is a particularly key issue, and some people find that eating becomes a really repulsive experience, and that's obviously a very hard thing for them to cope with and manage. So just a quick nod to head injury specifically, and how that affects sense of smell. As you can imagine, with head injury, there are a number of mechanisms of injury, from high impact to low impact. And obviously, with respect to the sense of smell, if there are associated facial injuries, this may have a role to play as well. So smell may be lost as a consequence of head injury from a number of reasons. Firstly, it may be due to direct bruising of the brain, so the area of the brain where you're receiving the signals. Some of it may be due to stretching or tearing of the olfactory nerve fibers as they cross through the base of the skull from the nose into the skull cavity. In some cases, if obviously there's an injury to the nose itself, that may cause problems with a conductive element, so stopping air flowing properly to the top of the nose. And of course, it's possible that some people may have a pre-existing problem in their nose, such as sinusitis. So in terms of the conductive component, as I said, if there's an injury that causes a fracture of the nasal septum, which is the midline partition of your nose, as you can imagine, that may then cause a block, allowing air to circulate properly to the top of the nose. And in some cases may set up a secondary acute sinusitis, causing further problems with swelling. But otherwise, in the absence of any specific nasal injury, as I say, we can see key ways that head injury causes a problem. Either causes the brain to bounce off the skull and causes sort of bruising and tearing, and either bleeding directly in the brain or bleeding around the brain, which can cause compression. But there's also this issue around the sort of tearing mechanism as the head moves back and forth, and we may see injury to the olfactory fibers. More recently, it's been thought that perhaps, although the nerve fibers may remain intact, the blood supply around those nerve fibers may be compromised by swelling in that area, and you may therefore get a secondary problem with neuronal cell death, because the blood supply is compromised, and so rather than the nerves themselves being directly injured, they're injured as a secondary effect because they're not getting the blood supply, and they therefore die off. Obviously, in severe head injury cases, if there's a direct frontal impact, you may get to direct trauma through bony fragments. So there are various places within the brain where we sort of have smell centers. The olfactory bulbs can be traumatized as they rub across the skull base. But the key area is this area at the front of the brain, in the frontal lobes, known as the orbital frontal cortex. And that's if there's injury in that area, it's a key area where we see things crop up on scans in patients that have had head injuries. As you'd imagine, the higher the severity of trauma, the higher the risk of problems with the sense of smell. So if you've got a low-grade injury, then it's an 18% chance, and traumatic brain injury grade 2 or 3 has over 50% chance of smell dysfunction. So typically what we do, and we see patients in clinic, is to request an MRI scan to look for areas of injury. And then maybe we get an MRI scan come back that looks completely normal, and it may be therefore that because what you can't see in MRI scans, you can't see the individual olfactory nerve fibers. So if there is tearing of that area, you won't see that. You only see sort of other issues with the brain. And so we may kind of come to a process of kind of assuming that that's where the level of injury lies if we don't see anything else. So there's some sort of common changes here in an MRI scan. We can see kind of what we call gliosis, or change in the brain cortex as a result of prior head injury. So in summary, it's a very common problem, smell loss. It's an undervalued problem, and the other thing to say that in head injury, which unfortunately my slide dropped out in the syncing process, is that it tends to be missed early on, because these people with head injury often maybe have other injuries going on. They may spend periods of convalescence in hospital or at home. And I see a lot of people with head injury who kind of tell me that, while they're in hospital and they didn't really sort of notice that they could smell or taste anything, and they just assumed it was the poor quality of the hospital food that was the problem. And it's only really when they get home and someone gives them a nice plate of home cooked food and they go, I'm not getting anything from this, and that suddenly the penny drops that they've actually had a problem. So it's definitely an overlooked area, and understandably, obviously, if there are multiple injuries and more severe injuries, those things have to take precedent. But it's an important area we're trying to emphasise people to pick up on much earlier in the process. So infrequently, I see people coming into my clinic sort of months to years after head injury, sort of suddenly asking for help, and the time for help is to get the help early on. Good. Okay. At that point, I'll finish and pause for any questions.
Thank you so much, Carl. I do have two questions. The first one was that it's fabulous that you have opened the first UK clinic in taste and smell disorders. Is there any plans for future clinics across other parts of the UK?
Yeah, so at Fifth Sense, we've been working, I think Duncan mentioned about the support hubs, and that's really in partnership with clinicians who are sort of looking to run clinical services to see patients with smell and taste disorders. So there is another dedicated smell and taste clinic at Birmingham under the auspices of my colleague Leisha McClelland. But we have a number of colleagues who specialise in the nose and sinuses, what we call rhinologists, who have special interest clinics. Duncan may have mentioned sort of centres in the northwest, such as Liverpool, in Dundee in Scotland, and colleagues in London as well. So there are places now sort of starting to kind of open up and invite more people in with smell and taste disorders.
Thank you very much. And the last question was, can people from other parts of the UK be signposted to your clinic?
Yeah, absolutely. No, we've been seeing people from all over the UK for the last decade, and so we're well versed in seeing people from far and wide. And I guess one of the advantages that the COVID pandemic has brought is that we do now have remote consultations available for people. So if people find it difficult to travel to the far east outposts of England, then we do have the option to do a video consultation with them. Obviously, it doesn't mean we can't examine them by that means, and we can't do the smell test by that means, but it does give an opportunity to talk to people. And obviously, if they've had scans previously, we can arrange those to be transferred onto our system and review those. So we can do quite a lot remotely, and it's only opened up opportunities.
Oh, and I thought that was the last question. I've got one more, apologies. Is there anything that SLTs can advise for patients with smell and taste loss with dementia to make eating and drinking better?
Yeah, I mean, I think stimulating sort of all aspects of sort of flavour, particularly sort of around taste and texture, are key things that can be emphasised. Remembering that food actually, well, there's obviously the visual aspect and even audible aspect. So there's sort of multi-sensory aspects of eating, which the non-olfactory bits can be emphasised, and I think that's it's important for people to understand that they can still rely on those bits. But also, if there is some residual smell there, is to emphasise stimulating the sense of smell. Interestingly, another meeting I was at a few years ago, a colleague sort of from the fragrance industry was talking about a study they did in residential homes, actually using familiar smells like the smell of Bakewell tarts, kind of, and a little sort of diffuser in the corner, actually was sort of comforting for people with Alzheimer's disease who did have some residual olfactory function. So they're actually using that to kind of for positive effect.
That is great. Thank you so much, Carl, and thank you for your time. I'm sure it has been a benefit to our attendees.